Vital signs, Potter, Perry, Chapter 30. The word vital gives its importance. The most frequent measurements obtained by healthcare providers are temperature, pulse, respirations, blood pressure, oxygenation, and what about pain? Pain is a subjective symptom and is frequently measured with the others. Measurement of vital signs provide data from which to determine a patient's usual state of health or their baseline data. When asking a patient to rate their pain, we want to ask them, what is your pain on a scale from 0, meaning no pain whatsoever, to 10, which would represent your worst possible pain that you could imagine. So on a scale from 0, no pain, to 10, worst possible pain, what would you rate your pain at this time? You can also use the little smiley faces with a very happy smile at 0 and then frowny with lots of tears for 10, and point to this and let the patient tell you which one reflects how they feel. This could be for a client that may be a child or either a client that does not speak English. So we want to look at why do we do vital signs, and as I said earlier, we want to use them to determine your baseline or your usual state of health for your client. The data is used to identify your nursing diagnoses, and we're going to talk a little bit more about nursing diagnoses later on. Also, factors that can cause change in temperature is the environment that the patient is in, your patient's physical exertion, or the effects of medication or the effects of illness that they have. You want to identify specific life-threatening clinical problems and select nursing interventions. Also, to determine the effects of surgery or other invasive procedures. Any variations from normal may indicate possible problems with the client's health status. Know expected values of vital signs, interpret your patient's values, communicate findings appropriately, and begin interventions as needed. Use the following guideline to incorporate measurements of vital signs into your practice. Measuring vital signs is your responsibility. You may delegate measurement of vital signs in selected situations, but you must review the results and interpret your findings. You can, if your patient is not critical, you could delegate this to an unlicensed personnel such as your tech or your CNA. But if your patient's vital signs or your patient is critical state, you would want to stay by that bedside and check those vital signs yourself. Assess your equipment to ensure that it is working correctly and provides accurate findings. Select equipment on the basis of the patient's condition and characteristics. For instance, do not use an adult-sized blood pressure cuff on a child, and do not use a child blood pressure cuff on an adult. Know the patient's usual range of vital signs. Know your patient's medical history, therapies, prescribed medications. Some illnesses or treatments cause predictable changes in vital signs, and some medications affect one or more vital signs. Control or minimize environmental factors that affect the vital signs, such as heat or cold, noise. Use an organized, systematic approach when taking the vital signs. Each procedure requires a step-by-step approach to ensure accuracy. On the basis of the patient's condition, collaborate with healthcare providers to decide the frequency of vital sign assessment. You, as the RN, has the autonomy to decide how frequently you need to check those vital signs. If the temperature is 104, you've just given them some medication, you want to make sure you're checking it frequently to make sure that that temperature is coming down. Or if the blood pressure is very high, you want to stay with that patient, give them medication, and check it more frequently to make sure that the blood pressure is coming down. So you have the autonomy to decide how often you check those vital signs. Also, the physician or the healthcare provider sometimes will write orders for you to check them at certain frequencies, and you would do that as well. Use vital sign measurements to determine indications for medication administration. Know the acceptable ranges for your patients before administering medications. Analyze the results of vital sign measurement on the basis of patient's condition and past medical history. Verify and communicate significant changes in vital signs. Baseline measurements provide a starting point for identifying and accurately interpreting possible changes. Throughout the PowerPoint, we'll have a case study, an unfolding case study. So we're going to start out with Miss Colburn. She's a 26-year-old school teacher. Her maternal grandparents immigrated to America from Brazil. She smokes 1 pack of cigarettes a day and has smoked since she was 16. She is also 20 pounds overweight. She made an appointment because she started to have headaches and frequently felt tired. Remember, Ms. Colburn is a 26-year-old smoker, and throughout the chapter, think about how her history will affect her vital signs. Despite extremes in environmental conditions and physical activity, temperature control mechanisms of humans keep body core temperature relatively constant. No single temperature is normal for all people. For healthy young adults, the average oral temperature is 37 degrees Celsius or 98.6 degrees Fahrenheit. In the elderly population, the average core temperature ranges from 35 to 36.1 degrees Celsius or 95 to 97 degrees Fahrenheit as a result of decreased immunity. The time of day also affects body temperature, with the lowest temperature at 6 a.m. and the highest temperature around 4 p.m., and this is in healthy people. Invasive measurements, such as with a pulmonary artery catheter, are considered core temperatures, whereas axillary temperatures are reflective of the surface temperature of the body. We'll go over all these temperature sites and different thermometers that we will be using in the hospitals in our skills lab. It is important to remember that a consistent body temperature measurement from a single site allows you to monitor patterns of your patient's body temperature. A process called thermoregulation controls the physiological and behavioral mechanisms that regulate heat loss and heat production. The relationship is regulated by 6 mechanisms: neural and vascular control, heat production, heat loss, skin temperature regulation, and behavioral control. The neural and vascular control is governed by the hypothalamus, this is located in the cerebral hemispheres. The hypothalamus works like a thermostat in establishing a comfortable body set point. The anterior hypothalamus controls heat loss, and the posterior hypothalamus controls heat production. Heat production is a byproduct of metabolism, a series of chemical actions that take place in the body. Food is the primary source of the body's metabolic process. Heat production occurs through the BMR, or your basal metabolic rate, as well as through shivering and non-shivering thermogenesis, which is reported in neonates. Heat loss occurs through the process of radiation, conduction, convection, and radiation. Evaporation. Radiation is the transfer of heat from the surface of one object to the surface of another without direct contact between the two. As much as 85% of the surface area of the human body radiates heat to the environment. Conduction is the transfer of heat from one object to another through direct contact. Convection is the transfer of heat away by air movement. Evaporation is the transfer of heat energy when a liquid is changed to a gas, as in diaphoresis or sweating. Skin temperature is an effect of its role in body insulation, vasoconstriction, and temperature sensation. Skin, subcutaneous tissue, and fat keep heat inside the body. Behavioral control depends on a person's ability to control body temperature through the degree of temperature extremes, the ability to sense comfort or discomfort, processes or emotions, the person's mobility or ability to add or remove clothing. In summary, thermoregulation constitutes the physiological and behavioral mechanisms that regulate the balance between heat loss and heat production. Let's go back to another case study. Miguel is a 42-year-old Hispanic nurse who works at the clinic. Ms. Colburn is visiting. He enjoys providing health-related teaching to the patients and has provided Ms. Colburn's care for 2 years. So during the visit, Miguel assesses Ms. Colburn's symptoms. He asks her about her headache and fatigue, then takes her vital signs. Her temperature is 98 degrees Fahrenheit. So think about what other vital signs does Miguel need to check. He's checked her temperature, but what other vital signs do you think are important as well? Factors affecting body temperature is your age, exercise, hormonal level, circadian rhythm, environment, and temperature alterations. Age has a great effect on body temperature. Newborns' temperature control mechanisms are immature. They can lose up to 30% of heat through their heads. That's why all newborn babies have the little caps that we put on their heads immediately after birth. Until a child reaches puberty, temperature regulation is unstable. Also note that it is not unusual for older adults to reach temperatures no higher than 96.8. Note that it is not unusual for older adults to reach temperatures no higher than 96.8 degrees Fahrenheit. Exercise stimulates muscle activity and requires an increased blood supply and increased carbohydrate and fat breakdown. Exercise will increase heat production and body temperature. Women experiencing greater fluctuations in body temperature than men. Hormonal variations occur during the menstrual cycle and menopause. Women may experience hot flashes caused by inability to control vasodilation and vasoconstriction. Circadian rhythm changes the body temperature over the 24-hour period. The lowest body temperature occurs between 1 and 4 a.m. The body reaches maximum temperature at 1800. The circadian rhythm does not change with age, but will change for those who work the night shift. This usually takes up to 3 weeks for the RN or the person to adjust when they're changing shifts. That's why you'll either work night shift or day shift, but you would not alternate back and forth because your circadian rhythm would be out of whack if you did. The environment influences body temperature as well. When entering a warm room, a person's body heat will rise. If outside without warm clothing, a person's body temperature may be low, owing to radiant and conductive heat loss. Temperature alterations are related to exercise heat production, excessive heat loss, minimal heat production, minimal heat loss, or any combination of these. Fever or pyrexia is usually not harmful if it stays below 39 degrees Celsius or 102.2 degrees Fahrenheit in adults, or below 40 degrees Celsius, 104 degrees Fahrenheit in children. Fever determination is based on several temperature readings at different times of the day compared with the usual value for that person at that time. Pyrogens elevate body temperature, acting as antigens and triggering immune system responses. The hypothalamus raises the set point and the body conserves heat, which causes chills, fevers, and feels cold. The chill phase resolves when the new set point, a higher temperature, is achieved. During the next phase, the plateau, the chills subside and the person feels warm and dry. If the new set point is overshot or the pyrogens are removed, the third phase of a febrile episode occurs. Febrile meaning with fever. The hypothalamus set point drops, initiating heat loss responses. The skin becomes warm and flush because of vasodilation. Diaphoreses, or sweating, assist in evaporative heat loss. When the fever breaks, the patient becomes afebrile, or without fever. These are words you need to learn. Pyrexia means fever. Febrile is a patient with fever, and afebrile is a patient without fever. Fever is an important defense mechanism. Mild temperature elevations as high as 39 degrees Celsius, 102.2 degrees Fahrenheit, enhance the immune system of the body. Fever patterns differ depending on the causative pyrogen. The term fever of unknown origin, or FUO, refers to a fever with an undetermined cause. During a fever, cellular metabolism increases and oxygen consumption rises. Body metabolism increases 10% for every degree Celsius of temperature elevation. Heart and respiratory rates increase to meet the metabolic needs of the body for nutrients. The increased metabolism uses energy that produces additional heat. If a patient has a cardiac or respiratory problem, the stress of a fever is great. A prolonged fever weakens a patient by exhausting energy stores. Increased metabolism requires additional oxygen. Important to know, if the body cannot meet the demand for additional oxygen, cellular hypoxia, or inadequate oxygen, occurs. Myocardial hypoxia produces angina or angina. This is chest pain. Cerebral hypoxia produces confusion. Interventions during a fever include oxygen therapy. I'm going to repeat this, it's very important. If the body cannot meet the demand for additional oxygen, cellular hypoxia, inadequate oxygen, occurs. Myocardial hypoxia produces angina or chest pain. Cerebral hypoxia produces confusion. Interventions during a fever include oxygen therapy. When water loss through increased respirations and diaphoreses is excessive, the patient is at risk for fluid volume deficit. Dehydration is a serious problem for older adults and children with low body weight. Maintaining optimal fluid volume status is an important nursing action. Hypothermia is an elevated body temperature resulting from the body's inability to promote heat loss or reduce heat production resulting from an overload of the thermoregulatory mechanisms of the body. However, malignant hypothermia is an inherited condition of uncontrolled heat production that occurs when susceptible people receive certain anesthetic drugs. Malignant hypothermia is an inherited condition of controlled heat production that occurs when susceptible people receive certain anesthetic drugs. Heat stroke is defined as a body temperature of 40 degrees Celsius or 140 degrees Fahrenheit or more, depresses hypothalamic function, and occurs from prolonged exposure to the sun or high environmental temperatures. This may be seen in those who spend time outside, such as athletes and construction workers. Signs and symptoms of heat stroke include giddiness, confusion, delirium, excessive thirst, nausea, muscle cramps, visual disturbances, elevated body temperature, increased heart rate, and lower blood pressure. Vital signs reveal a body temperature sometimes as high as 45 degrees Celsius or 113 degrees Fahrenheit, with an increased heart rate and lowering of blood pressure. The most important sign of heat stroke is hot, dry skin. The most important sign of heat stroke is hot, dry skin. Heat exhaustion occurs when profuse diaphoresis or sweating results in water and electrolyte loss. First aid includes transporting him or her to a cooler environment and restoring fluid and electrolyte balance. Hypothermia occurs with exposure to cold. The cold body temperature drops and the body is unable to compensate. When skin temperature drops below 34 degrees Celsius or 93.2 Fahrenheit, the patient suffers uncontrolled shivering, loss of memory, depression, and poor judgment. As the body temperature falls lower, heart rate, respiratory rate, and blood pressure also fall. The skin becomes cyanotic. Patients experience cardiac dysrhythmias, loss of consciousness, and unresponsive to painful stimuli if hypothermia progresses. When you suspect hypothermia, assessment of core temperature is critical. A special low-reading thermometer is required because standard devices do not register below 35 degrees Celsius or 95 degrees Fahrenheit. Frostbite occurs when the body is exposed to subnormal temperatures. Ice crystals form inside the cells, and permanent circulatory and tissue damage occurs. Knowledge of the physiology of body temperature regulation is essential to assess and evaluate a patient's response to temperature alterations and intervene safely. Identify your patient's values, beliefs, current treatments, and expectations regarding fever management. When possible, select the temperature site preferred by the patient. Include the patient's preferences when selecting non-pharmacological interventions for hyperthermia. Use a thermometer to obtain intermediate temperature measurements from the mouth, rectum, tympanic membrane, or temporal artery. Axillary temperature measurements are usually not recommended because they're not as accurate. The temperature obtained varies depending on the site used, but it is usually between 36 degrees Celsius or 96.8 degrees Fahrenheit and 38 degrees Celsius, which is 100.4 degrees Fahrenheit. Rectal temperatures are usually 0.5 degrees Celsius or 0.9 degrees Fahrenheit higher than oral temperatures. Devices include electronic and disposable versions. We'll go over all of these in our skills lab, and you will be using those as well. Maintaining cleanliness of the probes is a very important consideration. Thermometers use a Celsius or a Fahrenheit scale. Your core body temperature uses a urinary bladder probe or a central venous catheter, and these are used usually in your acute care settings or your ICUs. But we will show you these and go over those in our skills lab. When you're checking the oral temperature, you want to make sure that the client is able to hold the thermometer under their tongue and not bite it, that they can breathe okay, they're not eating or drinking or smoking, and if they are, you must wait 20 to 30 minutes before you can check that temperature orally. If you walk into the room and they're drinking tea or Coke or whatever, or coffee, wait 20 minutes and come back in to check it because it will affect your reading. Your rectal thermometer, you want to make sure that you lubricate with your KY jelly before you insert. And to check the temperature for the ear for a child, you want to pull the pinna down, and for the adult, you want to pull it up. Again, we will discuss all of this in your skills lab. You do need to know how to convert Fahrenheit to Celsius and to convert Celsius to Fahrenheit. Um, I'll post that for you and we'll go over that in class as well. So let's just have a quick quiz and see what you know so far. You have delegated vital signs to an assistive personnel. The assistant informs you that the patient has just finished a bowl of hot soup. The nurse's most appropriate advice would be A. Take a rectal temperature. B. Take the oral temperature as planned. C. Advise the patient to drink a glass of cold water. Or D. Wait 30 minutes and take an oral temperature. If you chose D, wait 30 minutes and take an oral temperature, you are correct. The consumption of hot liquids will affect the oral temperature readings. Just if you're going in to take, there's no reason for you to take a rectal temperature at this time. You certainly would not want to take the oral temperature as planned because they've just had a bowl of hot soup, and you don't want to have them to drink a glass of cold water after the hot soup because then it's still going to affect your reading. So D, wait 30 minutes and take an oral temperature. That would be the correct answer. Once you determine a nursing diagnosis, accurately select the related factor or etiology. The related factor allows you to develop, set appropriate patient goals, and select appropriate nursing interventions. Nursing diagnoses, you want to cluster your defined characteristics to form a nursing diagnosis. And some of the examples of nursing diagnoses for patients with body temperature alterations would be risk for imbalanced body temperature, hyperthermia, hypothermia, and ineffective thermal regulation. Again, we're going to discuss in greater detail your nursing diagnoses and the nursing process. During planning, you want to integrate the knowledge gathered from your assessment and the patient history to develop an individualized plan of care. Establish your expected outcomes to gauge process toward returning the body temperature to an acceptable range. In cases which the temperature alterations requires helping patients modify their environment, goals may be long-term. Short-term goals such as regaining normal range of body temperature improve your patient's health. You want to set priorities of care with regard to the extent that the temperature alteration affects a patient. The severity of a temperature alteration and its effects, together with the patient's general health status, influence your priorities in her care. Safety is a top priority. Often other medical problems can complicate the care plan. Patients at risk for imbalanced body temperature require an individualized care plan directed at maintaining normothermia and reducing risk factors. Education is particularly important for patients who need to know how to take action at home and whom to call when an infant or a child develops a temperature imbalance. Consider patient activity, temperature of the environment, and clothing. Teach patients to avoid strenuous exercise in hot, humid weather. Drink fluids such as water or clear, fruity juices before, during, and after exercise, and wear light, loose-fitting, light-colored clothes. Teach patients to avoid exercising in areas with poor ventilation. Wear a protecting covering over their head when outdoors, and expose themselves to hot climates gradually. Prevention is the key for patients at risk for hypothermia. It involves educating patients, family members, and friends. Patients at risk include the very young, the very old, and people that are debilitated by trauma, stroke, diabetes, drug or alcohol intoxication, and sepsis. Fatigue, dark colored skin, malnutrition, and hypoxemia also contribute to the risk of frostbite. Heat stroke is an emergency situation. First aid treatment includes moving the patient to a cooler environment, removing excess body clothing, placing cool wet towels over the skin, and using oscillating fans to increase convective heat loss. Emergency medical treatment includes providing intravenous fluids, irrigating the stomach and lower bowel with cool solutions, and using hypothermic blankets. The priority treatment goal for hypothermia is to prevent a further decrease in body temperature. Removing wet clothes, replacing them with dry ones, and wrapping patients in blankets are key nursing interventions. In emergencies away from a healthcare setting, have the patient lie under a blanket next to a warm person. A conscious patient benefits from drinking hot liquids such as soup and avoid alcohol and caffeinated fluids. It is helpful to keep the head covered, to place the patient near a fire or a warm room, or to place heating pads next to the areas of the body, head and neck, that lose heat the quickest. Educate the patient with a fever about the importance of taking and continuing any antibiotics as directed until the course of treatment is completed. Children and older adults are at risk for fluid volume deficit because they can quickly lose large amounts of fluids in proportion to their body weight. Identifying preferred fluids and encouraging oral fluid intake are important ongoing nursing interventions. Evaluate your patient's perspectives about the care provided, including the patient in the evaluation demonstrates that you value his or her perspective and contributes to patient safety. If therapies are effective, body temperature returns to an acceptable range, other vital signs stabilize, and the patient reports a sense of comfort. Electrical impulses originating from the SA node travel through the heart muscle to stimulate cardiac contraction. Approximately 60 to 70 milliliters of blood enters the aorta with each ventricular contraction. A pulse is a palpable bounding of blood flow noted at various points on the body, and this is an indicator of circulatory status. With each stroke volume ejection, the wall of the aorta distends, creating a pulse wave that travels rapidly toward the distal end of the arteries. The pulse wave moves 15 times faster than the aorta and 100 times faster than the small arteries that ejected the volume of blood. When a pulse wave reaches a peripheral artery, you can feel it by palpating the artery lightly against underlying bone or muscle. The pulse is the palpable bounding of blood flow in the peripheral artery. The number of pulse sensations occurring in 1 minute is the pulse rate. We will learn how to check pulse rates in our skills lab. The volume of blood pumped by the heart during 1 minute is the cardiac output, the product of heart rate and stroke volume of the ventricles. A change in heart rate or stroke volume does not always change the output of the heart or the amount of blood in the arteries. An abnormally slow, rapid, or irregular pulse alters cardiac output. Assess the ability of the heart to meet the demands of the body tissue for nutrients by palpating a peripheral pulse or by using a stethoscope to listen to heart sounds at the apical rate. You will select the most appropriate and age-specific site to measure the pulse. Typically, the radial artery is used because it is easy to palpate. When a patient's condition suddenly worsens, the carotid site is recommended for quickly finding and assessing the pulse. If the radial pulse is abnormal or intermediate, resulting from dysrhythmias, or if it is inaccessible because of a dressing or cast, assess the apical pulse. When a patient takes medication that affects the heart rate, the apical pulse provides a more accurate assessment of the heart function. The brachial or apical pulse is the best site for assessing an infant or a young child's pulse because other peripheral pulses are deep and difficult to palpate accurately. When measuring the apical site, you will need to use a stethoscope. To ensure the best reception of sound, the earpiece follows the contour of the ear canal pointing toward the face with the stethoscope in its place. Before measuring a pulse, review the patient's baseline rate for comparison. The temporal, the carotids, the apical, the brachial, the radial, the femoral, popliteal, posterior tibia, and dorsalis pedis are all areas of pulse sites. Let's look at the parts of your stethoscope. There are 5 major parts. They are the earpieces, the binaurals, the tubing, the bell chest piece, and the diaphragm chest piece. We'll learn how to hold our stethoscopes, put them in our ears the correct way, and listen either by the bell or the diaphragm. The diaphragm is the circular, flat portion of the chest piece covered with a thin plastic disc. It transmits high-pitched sounds created by high-velocity movement of air and blood. The bell is the bowl-shaped chest piece, and it's usually surrounded by a rubber ring. The bell transmits low-pitched sounds created by low-velocity movement of the air. Auscultate heart and vascular sounds with the bell. Postural changes affect the pulse rate because of alterations in blood volume and sympathetic activity. The heart rate increases when a person changes from a lying to a sitting or standing position. When assessing the pulse, consider the variety of factors influencing the pulse rate. Assess the apical pulse by listening to the heart sounds. Identify the first and second heart sounds, S1 and S2. At normal slow rates, S1 is low-pitched and dull, sounding like a lub. S2 is higher pitched and shorter, creating the sound of dub. Count each set of lub-dub as one heartbeat. Using the diaphragm or the bellow stethoscope, count the number of lub-dubs occurring in 1 minute. 2 common abnormalities in pulse rates are tachycardia and bradycardia. Tachycardia is an abnormally elevated heart rate above 100 beats a minute in adults. Bradycardia is a slow rate below 60 beats a minute in adults. An ineffective contraction of the heart that fails to transmit a pulse wave to the peripheral pulse site creates a pulse deficit. To assess a pulse deficit, you and a colleague assess radial and apical rates simultaneously and then compare the rates. The difference between the apical and the radial pulse rates is the pulse deficit. Know what tachycardia is, bradycardia, and know what a pulse deficit is. Normally, a regular interval occurs between each pulse or heartbeat. An interval interrupted by an early or late beat or a missed beat indicates an abnormal or a dysrhythmia. A dysrhythmia threatens the ability of a heart to provide adequate cardiac output, particularly if it occurs repetitively. You identify a dysrhythmia by palpating an interruption in successive pulse rates or auscultating an intervention between heart sounds. To document a dysrhythmia, the healthcare provider often orders an electrocardiogram or an ECG, a heart monitor, Holter monitor, or a telemetry monitor. And we will go over those in class in our skills lab and show you the difference in all of those. The strength and amplitude of a pulse reflects the volume of blood ejected against the arterial wall with each heart contraction and the condition of the arterial vascular system leading to the pulse site. Document the pulse strength as bounding would be a 4, full or strong would be a 3, normal and expected is a 2, diminished or barely palpable is a 1, or absence is a 0. Include assessment of pulse strength in the assessment of the vascular system. Assess radial pulses on both sides of the peripheral vascular system, comparing the characteristics of each. Assess all symmetrical pulses simultaneously except for the carotid pulse. Never measure the carotid pulses simultaneously because excessive pressure occludes blood supply to the brain. Your patient will faint. When assessing your pulse, if you cannot feel the pulse, you can use a Doppler. In the top right corner is the picture of a Doppler. We have one in the skills lab and we'll show you how to use that. If you do not feel the pulse, then you would use a Doppler. You would not just rate it as a 0 that the pulse is absent until you check it with the Doppler first. Your radial artery is your most common site, and to assess pulse measurement, apply light pressure over the client's artery with the pads of your 2 middle fingers. Press firmly to detect pulse without occluding the artery. You never use your thumb because your thumb has a pulse and you'll be counting your own pulse instead of your client's. The pads of 2 middle fingers, never the thumb. Your stethoscope is used to auscultate bowel, lung, and heart sounds using the diaphragm or your high-pitched sounds. The bell is to auscultate heart and vascular sounds using the low-pitched sounds. Locating your pulses, your peripheral or your apical. And we'll talk about both of those in just a minute. Measuring your apical radial pulse. Remember, get with your colleague. If your pulse is different, get with your colleague and have them to measure the apical while you measure the radial. And the apical pulse rate exceeds the radial pulse rates, that would be called a pulse deficit. When the apical pulse rate exceeds the radial pulse rate, that is called a pulse deficit. The apical pulse is the heart rate counted at the apiece of the heart on the anterior chest. Used for given medications, it's a more accurate measurement. As you can see, the fifth rib in the midline with the clavicle is where you will find your apical impulse. You would count it for 1 full minute. And a lot of medications will say apical pulse before giving medication. So you would count the apical pulse and make sure that your pulse is at least 60 before you would give that medication. We'll talk a little bit more about that in class. Pulse assessment determines the general state of cardiovascular health and the response of the body to other system imbalances. Tachycardia, bradycardia, and dysrhythmia are defining characteristics of many nursing diagnoses, including the ones on the slide that I've got up there. The nursing care plan includes interventions based on the nursing diagnoses identified and the related factors. And when the related factors is inactivity following prolonged illness, interventions focus on increasing the patient's daily exercise routine. Once the plan is implemented, you want to evaluate your patient outcome by assessing his or her pulse. And we will, these are just several of the nursing diagnoses that we'll talk about that affect the pulse determination. Okay, it's time for another quiz to see what we've learned so far. You notice that a teenager has an irregular pulse. The best action you should take includes A. Reading the history and physical. B. Assessing the apical pulse rate for 1 full minute. Auscultating for strength and depth of the pulse. And D. Asking whether the patient feels any palpitations or faintness of breath. You notice that a teenager has an irregular pulse. Your best action would include, if you selected B, assessing the apical pulse rate for 1 full minute, you are correct. Normally you would check the radial pulse, but if it is irregular, you want to check then the apical pulse for 1 full minute. Respiration includes 3 processes, which is your ventilation, diffusion, and perfusion. You will analyze respiratory efficiency and ventilation by assessing the respiratory rate, the depth, and the rhythm. Remember, breathing is a passive process. You can hold your breath until you die, but you will not be able to do that, because after you faint, you will start breathing again. It is a passive process. The brainstem regulates involuntary control. The body regulates ventilation through CO2 and O2 and hydrogen ion concentrations in your arterial blood. If oxygen falls below the acceptable parameters, respiratory rate and depth of ventilation will increase. Hypoxemia is a low blood level of oxygen. Hypoxemia helps to control ventilation in patients with chronic lung disease. Because low levels of arterial O2 provide the stimulus that allows a patient to breathe, administration of high oxygen levels is fatal for patients with chronic lung disease. I'm going to say this one more time. Hypoxemia, which is a low blood level of oxygen, hypoxemia helps to control ventilation in patients with chronic lung disease. Because low levels of arterial O2 provide the stimulus that allows a patient to breathe, administration of high oxygen levels is fatal for patients with chronic lung disease. Ventilation of normal rate and depth is called eupnea. Measurement of arterial oxygen saturation, or SaO2, is the percent of hemoglobin that is bound with oxygen in the arteries. Usually, the normal is between 95 to 100%, and we measure this with a pulse oximetry. And we have digit, earlobe, and disposable. This is a picture here of a digit pulse oximetry, and we'll go over each one of these in our skills lab. A pulse oximetry permits the indirect measurement of oxygen saturation. The pulse oximetry is a probe with a light-emitting diode, LED, connected by cable to an oximeter. And the LED emits light wavelengths that the oxygenated and deoxygenated hemoglobin particles absorb differently. A photodetector in the probe detects the amount of oxygen bound to hemoglobin molecules, and the oximeter calculates the pulse saturation. Your pulse saturation is a reliable estimate of your arterial oxygen saturation when the O2 stat is greater than 70%. A saturation of less than 90% is a clinical emergency. The photodetector is in the oximeter probe. Selecting the appropriate probe is important to reduce the measurement error. Factors that affect light transmission or peripheral arterial pulsations affect the ability of the photodetector to measure the SO2 correctly. For instance, if your client has fingernail polish on, you would need to take that fingernail polish and remove it, because that would affect that light transmission. So before you can get an accurate reading, you must make sure that the fingernail polish is removed, or if they have artificial nails on, that would have to come off before you could get an accurate reading for your client. This illustration shows the diaphragmatic and chest wall movement during inspiration and expiration. Although breathing is passive, muscular work is involved in moving the lungs and chest wall. Expiration is passive. During inspiration, the respiratory center sends impulses along the phrenic nerve, causing the diaphragm to contract. During expiration, the diaphragm relaxes and the abdominal organs return to their original position. Accurate measurements requires observation and palpation of chest wall movement. Do not let a patient know you are assessing their respirations. A patient aware of the assessment can alter the rate and depth of breathing. Assess respirations immediately after measuring your pulse rate with our hand still on the patient's wrist as it rests over the chest or abdomen. When assessing a patient's respirations, keep in mind that the patient's usual ventilator rate and pattern, the influence any disease or illness has on the respiratory function, the relationship between respiratory and cardiovascular function, and the influence of therapies on respirations. Observe a full inspiration and expiration when counting ventilation or respiration rate. The usual respiratory rate varies with age. The usual range declines throughout life. A respiratory rate above 27 breaths a minute is an important risk factor for cardiac arrest. Respirations for an adult would be 12 to 20. Here's a list of alterations in breathing patterns. You do need to know what these words mean. Bradypnea is a rate of breathing is regular but abnormally slow, less than 12 breaths a minute. Tachypnea is a rate of breathing is regular but abnormally rapid, greater than 20 breaths a minute. I said the normal rate for the adult is 12 to 20. So if they're going to have abnormally low, it would be less than 12. If it's going to be abnormally rapid, it would be greater than 20 on our adult patient. Hyperpnea or respirations are labored, increased in depth, and increased in rate, greater than 20 breaths a minute, and this occurs normally during exercise. Hyper meaning greater than, and then pnea meaning breathing. Apnea, when your respirations cease for several seconds. Persistent sensation results in respiratory arrest. Apnea, no breathing. Respirations cease for several seconds. Hyperventilation, rate and depth of respirations increased. Hypoventilation, respiratory rate is abnormally low and depth of ventilation is depressed. Cheyne-Stokes respiration, this is your respiratory rate and depth are irregular, characterized by alternating periods of apnea and hyperventilation. Apnea, no breaths, and then hyperventilation. Respiratory cycle begins with slow, shallow breaths that gradually increase to abnormal rate and depth. The pattern reverses. Breathing slows and becomes shallow, climaxing in apnea before respirations return. Kussmaul's respirations. These are abnormally deep, regular, and increased in rate. Kussmaul respirations, abnormally deep, regular, and increased in rate. Biot respirations are abnormally shallow for 2 to 3 breaths, and this is usually followed by an irregular period of apnea or no breathing. Let's go on with our case study. Miguel is the student nurse, and he continues to take Miss Colburn's vital signs. Miss Colburn's respiratory rate is 14 breaths per minute, and her pulse is 86 beats per minute. Are these vital signs within normal limits? So Miss Colburn's respiratory rate is 14. I told you that adult is 12 to 20, so is 14 within normal rate? And then the pulse is between our heart rate. Pulse and heart rate is the same. Normally 60 to 100. So 86 beats per minute would be within normal limits. Normal heart rate for an adult, 60 to 100 beats a minute. Factors influencing character of respirations. Look on box 30-7 on page 501 in your book. Listed here are some of the nursing diagnoses that would go with your respirations. They include activity intolerance, acute pain, anxiety, ineffective airway clearance, ineffective breathing pattern, impaired gas exchange, ineffective peripheral tissue perfusion, and dysfunctional ventilatory weaning responses. All right, let's have another quick quiz. A postoperative patient is breathing rapidly. You should immediately A. Call the physician, B. Count the respirations, C. Assess the oxygen saturation, D. Ask the patient if he feels uncomfortable. A postoperative patient is breathing rapidly. You should immediately If you chose C, assess the oxygen saturation, you are correct. Shortness of breath is an indicator of hypoxemia. Remember, we talked about hypoxemia? Assessing the oxygen saturation will let the nurse know if the patient's breathing status is a result of hypoxemia. Shortness of breath is an indicator of hypoxemia. Your blood pressure is the force exerted on the walls of an artery by pulsing blood under pressure from the heart. Systolic is the maximum peak pressure during ventricular contraction, and diastolic is the minimal pressure during ventricular relaxation. And then your pulse pressure is the difference between your systolic and your diastolic pressures. Your standard unit for measuring blood pressure is millimeters of mercury, mmHg. This measurement indicates the height to which blood pressure raises a column of mercury, and you record blood pressure with the systolic reading before the diastolic. For instance, the blood pressure is 120/80. The difference between systolic and diastolic pressure is the pressure pulse, or the pulse pressure. For a blood pressure of 120/80, the pulse pressure would be 40. So pulse pressure is the difference between the systolic and the diastolic readings. Blood pressure reflects the interrelationship of cardiac output, peripheral vascular resistance, blood volume, blood viscosity, and artery elasticity. The volume of circulating blood affects the blood pressure. Normal circulating volume is 5,000 milliliters. An increase in volume exerts more pressure against the arterial walls. So when a person's circulating blood volume falls, as in the case of a hemorrhage or dehydration, your blood pressure is going to fall. The thickness of viscosity of blood affects the ease in which blood flows through the small vessels. The hematocrit, or the percentage of red blood cells in the blood, determines the blood viscosity. When the hematocrit rises and the blood flow slows, arterial blood pressure increases. The heart contracts more forcefully to move the viscous blood through the circulatory system. Your normal arterial walls are elastic and easily distendable. As blood pressure increases, the diameter of the vessel increases to accommodate the pressure. As pressure within the arteries increases, the diameter of the vessel walls increases to accommodate the pressure change. Arterial distendability prevents wide fluctuations in your blood pressure. Blood pressure is not a constant. Many factors influence blood pressure. Blood pressure can be further classified as normal, pre-hypertensive, stage 1 hypertensive, and stage 2 hypertensive. Stress created by anxiety, fear, pain, emotions cause sympathetic stimulation, which increases your heart rate, cardiac output, and vascular resistance. The incidence of hypertension is higher in African Americans than in European Americans. Genetic and environmental factors are also contributing factors. No clinical differences between boys and girls have been noted. However, after puberty, males tend to have higher blood pressure. After menopause, women tend to have higher blood pressure than men of similar ages. Blood pressure will vary during the day around sleep intervals and activities. Blood pressure is highest around 10 and 1800 hours. Blood pressure is lowest between hours of sleep and 0300. As a person wakes up, the blood pressure will rise. Medications will directly or indirectly alter blood pressure. Antihypertensives alter blood pressure directly. Indirectly, opioid analgesics lower blood pressure and volume, and vasoconstrictors raise blood pressures. Activity and weight are directly linked. A period of exercise can reduce blood pressure for several hours. Inadequate exercise contributes to weight gain and perhaps obesity, which can trigger hypertension. Smoking directly affects vessels, producing vasoconstriction, which causes blood pressure to rise. Next, let's compare hypertension versus hypotension. Hypertension is more common than hypotension. Hypertension is often asymptomatic. Prehypertension is diagnosed in adults when an average of 2 or more readings on at least 2 subsequent visits is between 120 and 130 millimeters of mercury systolic and 80 to 89 millimeters of mercury diastolic. Diastolic readings greater than 90 millimeters of mercury and systolic readings greater than 140 millimeters of mercury define hypertension. Hypertension is associated with thickening and loss of elasticity in the arterial walls. Peripheral vascular resistance increases within thick and inelastic vessels. The heart continually pumps against your greater resistance. As a result, blood flow to vital organs such as your heart, your brain, and your kidney decreases. Modifiable risk factors include obesity, smoking, alcohol consumption, and high salt intake. A person has no control over family history. Higher incidence of high blood pressure is seen in those with diabetes, older adults, and those of African American descent. Hypotension occurs because of the dilation of the arteries in the vascular bed, the loss of a substantial amount of blood volume or hemorrhage, or the failure of the heart muscle to pump adequately, such as with a myocardial infarction. Hypotension associated with pallor, skin molting, clamminess, confusion, increased heart rate, or decreased urine output is life-threatening and reported to a healthcare provider immediately. Orthostatic hypotension, also referred to as postural hypotension, occurs when the normosensitive person develops symptoms and a drop in systolic blood pressure by at least 20 millimeters of mercury, or a drop in diastolic pressure by at least 20 millimeters of mercury within 3 minutes of rising to an upright position. Patients who are dehydrated, anemic, or have experienced prolonged bed rest or recent blood loss are at a great risk for orthostatic hypotension, particularly in the morning. Again, patients who are dehydrated, anemic, or have experienced prolonged bed rest or recent blood loss are at risk for orthostatic hypotension, particularly in the morning. Assess for orthostatic hypotension during measurements of vital signs by obtaining blood pressure and pulse in sequence with the patient supine. Check their blood pressure, have them lie there for 3 minutes, sit them up, check their blood pressure, have them sit there for 3 minutes, have them stand, check their blood pressure, and then compare those 3 blood pressures with them lying, sitting, and standing. While obtaining orthostatic measurements, observe for other symptoms of hypotension such as fainting, weakness, blurred vision, or lightheadedness. Orthostatic hypotension is a risk for falls, especially among elderly patients with hypertension. When recording orthostatic blood pressure measurements, record the patient's position in addition to the blood pressure measurements. Let's continue with our case study. Ms. Colburn's blood pressure is 164/98 millimeters of mercury. Ms. Colburn asked, I think that's close to where it was last time I came in. Is that okay? So how would you respond to Ms. Colburn's question? Do you think her blood pressure is okay? Well, we talked about that a blood pressure is 120, less than 120 over less than 80. So the systolic would be less than 120, the diastolic would be less than 80, 80 or less. Those would be your normal values, and hers is 164/98. So we would probably advise her that it is a little high, and maybe give her some education on some lifestyle changes, and the physician may even prescribe some medication for this. Miguel responds, Ms. Colburn, your blood pressure is pretty high right now. After you see the nurse practitioner today, I'm going to take your blood pressure again. We're going to talk about the changes you can begin to make to help you be healthier and feel better. The patient's position during the routine blood pressure needs to be the same during each measurement so you can have a meaningful comparison of your values. Before obtaining the patient's blood pressure, attempt to control factors responsible for high readings such as pain, anxiety, or exertion. If they've been running up and down the hall or just got up and had a big meal, wait just a little while before you check their blood pressure. During the initial assessment, obtain and record the blood pressure in both arms. Normally, there is a difference of about 5 to 10 millimeters of mercury between the arms. In subsequent assessments, measure the blood pressure in the arm with the higher pressure. And when you're documenting, be sure to put blood pressure 120/80 right arm or left arm. Wherever you check it, document which arm you've used. Pressure differences greater than 10 millimeters of mercury indicate vascular problems and are reported to the healthcare provider or the nurse that's in charge. Ask the patient to state his or her usual blood pressure. If the patient does not know, inform him or her after measuring and recording it. Comparing your upper extremity blood pressure with that in the legs is also necessary sometimes for patients with certain cardiac or blood pressure abnormalities. You can use the popliteal artery, and to do so you'll want to palpate behind the knee in the popliteal space, and this is the site for auscultation. The cuff needs to be wide and long enough to allow for the larger girth of the thigh. Place the patient in a prone position if at all possible, but if that position is impossible, just ask the patient to flex the knee, as it is in the picture here, and position the cuff above the popliteal artery at mid-thigh. Position the cuff about 1 inch above the popliteal artery with the bladder over the posterior aspect of the mid-thigh. The procedure is identical to brachial artery auscultation. Your systolic pressure in the legs is usually higher by 10 to 40 millimeters of mercury than the brachial artery, but the diastolic pressure would be the same. I repeat, the procedure is identical to brachial artery auscultation, but your systolic pressure in the legs is usually higher by 10 to 40 millimeters of mercury than in the brachial artery. But the diastolic pressure is the same. The electronic devices are easier to manipulate but require frequent recalibration more than once a year. Because of their sensitivity, improper cuff placement or movement of the arm causes electronic devices to give incorrect readings. But the benefits of the electronic devices is that sometimes elevated blood pressure is detected in people previously unaware of a problem, and also it can provide the pattern of blood pressure values to the healthcare provider, and it also helps with adherence to treatment. The disadvantages of self measurement include improper use of the device and risk of inaccurate reading, and some patients are needlessly alarmed with one elevated reading, and some patients with hypertension become overly conscious of their blood pressure and inappropriately self adjust the medications. The assessment of blood pressure, along with pulse assessment, evaluates the general state of the cardiovascular health and responses to other imbalances. And the nursing care plan includes interventions based on your nursing diagnoses identified and your related factors. We're going to go over those in class, and also you have a nursing diagnostics book. So you'll need to bring that to class so I can show you how to use that book. All right, let's look at our case study again. Miguel determines that the priority is to focus on hypertension and ways to prevent or control elevated blood pressure. He states, we need to watch your blood pressure and closely over the next we need to watch your blood pressure closely over the next few weeks. In the meantime, remember you decided that you're going to walk for at least 15 minutes 3 times a day or 3 times a week. You are also going to try to eat foods with less salt and consider not smoking. Miss Colburn says, I don't know if I can quit right now. I have a lot going on, but I can do the walking and watch my salt. What outcome would you suggest for the interventions Miss Colburn and Miguel have agreed upon? It's very important to use teaching strategies to inform Miss Colburn not only of the lifestyle changes she must accommodate, but the reasons why each change is very valuable. Let's have one more quiz. When assessing the blood pressure of a school-aged child, using an adult cuff of normal size will affect the reading and produce a value that is accurate, indistinct, falsely high, falsely low. When assessing the blood pressure of a school-aged child, using an adult cuff of normal size will affect the reading and produce a value that is, remember this is a child and you're using an adult cuff with that child. If you chose falsely high, you are correct. Children should only have their blood pressure taken with an appropriately fitting cuff. Otherwise, it will skew the results. Specifically, if an adult cuff is used on a child, the blood pressure reading will be falsely high. The emphasis on health promotion and maintenance and discharge from hospital settings has resulted in an increase in the need for patients and their families to monitor the vital signs at home. When considering how to teach your patients and their families about vital sign measurements and their importance and significance, a patient age is a very important factor. With an increase in the older adult population, there is a greater need for family caregivers to be aware of the changes that are unique for those older adults as well. Okay, Miss Colburn has returned several weeks later. She's feeling better and is optimistic about the changes she is making to improve her health. After talking with Miguel a minute, Miss Colburn tells him, I got one of those electronic blood pressure monitors for myself. If I'm going to do all of this, I might as well see my progress. I'm not sure what I'm looking for though. So, what are some of the strategies that you would um, suggest for Miguel to use with Miss Colburn? Maybe you could have Miguel could have her demonstrate, and he could observe Miss Colburn practice taking her own blood pressure, and then he could evaluate her technique and provide guidance as needed. Um, you could also ask Miss Colburn to state 3 risk factors for hypertension to make sure that she understands fully what the risk factors are and what she's doing about them. Review her walking activities, so since she said she could walk, and talk to her about salty foods and is she avoiding those, and ask her, does she understand how to read the labels uh, to check for the sodium content of foods. And then you might talk with her and discuss with her if she's ready to quit smoking now. Remember, she said that she didn't feel like she could quit smoking, but she could do the other things. So maybe it's time now that we can talk with her about uh, quit smoking cessation classes, or some more information that we might have for her. Recording your vital signs. You want to record your values on electronic paper or paper graphic. In your patient's chart, there will be a graphic there for you to document your vital signs. Record in the nurse's notes any accompanying or precipitating symptoms. If the blood pressure is high, you want to make sure you're documenting that it is high, and if medication was given for that elevated blood pressure, or vital signs, you'd certainly want to document that in the nurse's notes, that the temperature, blood pressure, respirations, whatever was abnormal, you would document that finding, and then document that you did give medications per orders to help with that. Then you'd want to go back and document that you rechecked, evaluated the medication that was given, and document that as well. Um, Ensure patient safety is an essential role of professional nurse, and to ensure patient safety, you want to make sure that you communicate clearly with the members of the healthcare team. You want to assess and incorporate the patient's priorities of care and their preferences. Um, Use the best evidence when making decisions about your patient's care. When performing the skills, remember the following points to ensure safe and individualized patient-centered care. You want to make sure your devices for measuring the vital signs are often shared among other patients, so you want to make sure you're cleaning those devices between your patients so that you can decrease the risk for infection. Um, Rotate the sites during repeated measurements of blood pressure and pulse oximetry so you can decrease the risk for skin breakdown. You want to analyze the trends for measuring vital signs and report abnormal findings to the healthcare provider. And you want to determine the appropriate frequency of measuring the vital signs based on the patient's condition. Remember, I said at the very beginning that RNs have the autonomy to decide how often that they need to check those vital signs. And so the measurement of blood pressure, we're going to talk about the equipment, auscultation, palpation, lower extremity, electronic blood pressure, all of this in our skills lab. And this is just a picture showing the pressure of blood in the arteries is higher during systole. If you can look at during the heart contracts during systole, and lower during diastole when the heart muscles relax. So the pressure of the blood in the arteries is higher during systole when the heart contracts, and lower during diastole when the heart muscles relax. Hence the term systolic and diastolic pressure. Patient conditions not appropriate for electronic blood pressure um, measurement, and that would be an irregular heartbeat, uh, peripheral vascular obstruction, clots, narrow vessels. If the patient is shivering, or maybe they're having a seizure, or maybe they're having excessive tremors, um, are they inability to cooperate, or if the blood pressure is less than 90 millimeters of mercury systolic. So all of these are conditions. If your patient is having any or all of these conditions, then you would not use an electronic blood pressure cuff. So, benefits of your patient measuring their own blood pressure: um, detection of new problems. Patients with hypertension can provide their healthcare provider info about the patterns. Self-monitoring helps them to adhere to the therapy. Some of the disadvantages would be improper use, risk, inaccurate readings, unnecessary alarming of the patient if they, especially if they read the blood pressure inaccurately, and it's really high. It could alarm them, and then they might, make adjustments in their medications by what readings they get instead of calling the physician or coming into the office. So there are benefits and disadvantages of having the patient check their blood pressures at home. But we should always teach the patient that before they make any adjustments, check the blood pressure twice and then call the physician before they make any kind of adjustments with their medication. Okay, Korokov sounds. There was a Russian surgeon, and he first describes the sounds heard over an artery distal to the blood pressure. And he called this Korokov sounds because his name was Korokov. And there are 5 distinctive phrases of sounds heard with a stethoscope during auscultation. And we're going to go over this in class as well. The first phase, when you're listening with your stethoscope, you hear a clear tapping, and that's called systolic. Phase 2 will be your murmur or your swishing sound. Phase 3 will be your clear, intense tapping. Phase 4 is the distinct sound changes to a muffled sound. And then 5 is silence, which would be your diastolic in your adolescents and adults. Hypertension: if the patient has hypertension, you may not hear that phase 2, and this is called your auscultatory gap. And if they do have hypertension and you miss that phase 2, then you could make a mistake and think that phase 3 as systolic, and then you would have a false low reading. Use your Doppler if Korokov sounds are not heard. Again, we're going over this slide in great detail in class, but just be familiar with what Korokov sounds are and that it is 5 distinctive phrases of your sound heard with a stethoscope when checking your blood pressure. So again, we're going to go over this in great detail in class. All right, so let's go on with our case study. After caring for Ms. Colburn, Miguel sees the need to educate Ms. Colburn about the different types of vital signs, and Miguel determines that the priority is to focus on hypertension and ways to prevent or control elevated blood pressure. He states, "We need to watch your blood pressure closely over the next few weeks. In the meantime, remember, you decided that you're going to walk at least 15 minutes 3 days a week. You are also going to try to eat foods with less salt and think about not smoking anymore." It is very important that you use teaching strategies to inform Ms. Colburn not only of the lifestyle changes, but the reasons why each change is very, very valuable. So when you're teaching your patients regarding their vital signs, it's important to emphasize health promotion activities. You may need to teach the patient and their families to assess and record vital signs, and stress that the vital signs should be taken at the same time every day. Food and activity will alter the readings. And remember, the time of day will alter the readings. So these are some teaching strategies to give your client. Okay, Ms. Colburn has purchased an electronic blood pressure device for home use. So what evaluation strategies would you suggest for Miguel to use with Ms. Colburn? Well, you might ask Ms. Colburn to state 3 factors for hypertension. Have her to demonstrate and observe Ms. Colburn, again, taking her own blood pressure. You want to evaluate her technique and provide guidance if she needs it. Review her walking activities since the last visit, um, and talk to her about the salty food she's avoiding, and again, reading those labels, um, especially on canned foods. Try to purchase fresh or frozen fruits and vegetables versus canned, because canned foods are high in sodium. And then talk to her again about quitting smoking. Identify institution procedure for documenting on a graphic. Sometimes we have electronic documentation. Sometimes we still use the manual charting. So whatever your institution uses, that's what you will do, and we'll go over both so you'll know how to do both. And in addition to the actual vital sign values, record in the nurse's notes any accompanying or precipitating symptoms such as chest pain and dizziness with abnormal blood pressure, shortness of breath with abnormal respirations, cyanoses with hypoxemia, or flushing and diaphoresis with elevated temperatures. Patients being managed on critical paths or care maps often have vital signs listed as outcomes. Documenting your vital signs if you have to use the popliteal artery. If you can't use the patient's arms, you're going to use a thigh-sized cuff. Your systolic pressure can differ by 10 to 40 millimeters of mercury in the brachial, but the diastolic is going to remain the same. Document the reading is from the thigh. Initial readings, both arms for baseline, use same arm thereafter. Nurses are responsible for assuring that the vital signs have been assessed and documenting the reading, the location, and the position the patient was in. This is an area where delegation to unlicensed personnel should be carefully considered. And then your safety guidelines: cleaning the devices, rotating sites, analyze trends for vital signs, report any abnormal findings, and determine the appropriate frequency of measuring vital signs based on the patient's condition. This ends our lecture.